Welcome to Helping Today's Woman. I'm your host, Dr. Kelly Williams. As always, this show is designed to help women become champions of their own healthcare. Tonight we're going to talk about a topic that is really changing surgery as we know it in the modern times. Now, most people think of the robot as a science fiction Star Wars idea, but the robot has now arrived in the operating room in your local communities. So to help us better understand this change and how it's affecting surgery, I have invited Scott Sanderson, who is a surgical rep, for the DaVinci Surgical System. And I just want to start by saying thank you for being here. Now, we're going to talk a little bit about what the robot is and how it's involved in surgical care. So thanks again, Scott, for being here. I appreciate it.
My pleasure. Thank you for having me.
Now, I want to start off by just we talked a little bit about the fact that we've gone from science fiction to the operating room. How do we make this change, and where did all this begin?
Sure. About the late 1980s, there was a company that originally developed the technology. I contracted with the military, specifically the Army, to work on doing remote surgeries out in the battlefield. Right. So to have a surgeon back in a safe location, be able to do an operation on the battlefield to wounded soldiers. The genesis of Intuitive Surgical came and grew out of that. So as the designers were working on that platform, they realized that there was an opportunity in the community setting and in the commercial setting to expand and utilize that technology, and that's where we're at today.
And I want to talk a little bit about that because I think it's interesting, because a lot of people talk about this whole idea of remote surgery. And we talked about this a little bit earlier, the whole idea that you can take something like you're talking about in the battlefield, and now in the civilian world, are we getting to that point too? Are we getting to where we are going to be able to do remote surgery in the civilian world? There
are trials that are currently going on to test that. The technology exists to do remote surgery. Where we're I think the issue is running into is if you imagine a satellite interview that we see on the news, there's always that 2-3 second delay. Right. They're dealing with that similarity in remote robotic surgery, and so as with the addition of fiber optic cables and streamlining some of that to real time, I think we'll see that in the not too near future.
And I want to mention this because I think it's important. The whole idea we're talking about here of having remote surgery is not the fact that your doctor would be remote from you. The robotic system requires that the physician be there. It's the whole idea that we possibly bring specialists to areas where they're not right now. Is that right?
Exactly. You could have an underserved community or more rural community that did not have access to a specialist in a particular field, or have the tops in the world in a particular specialty be able to perform a remote surgery. So yes, you would still need an on-site surgeon at the location of that particular surgery, but that is the opportunity that's out there.
And there's the other thing is this is not the robot that walks and talks and comes up to the operating table. This is a little bit different. Describe to us a little bit about what's involved in robotic surgery and what are we talking about?
Sure. The DaVinci Surgical Platform is made up of 3 modular components. It's got a surgeon console where the surgeon is actually going to sit at and do the surgery, where he's in control at all times. There's a patient cart that comes up and docks next to the patient that the instruments are attached to. And then there's a 3D HD vision cart that provides the superior visualization that the surgeons are able to watch as they perform their surgeries.
And I know there's a couple of things that are really important about this. Where the console, where the surgeon who's operating is seeing, it's not in 2D like we do right now. We do right now something called laparoscopy, which is where we make small incisions and place a camera in there, and we're looking at a TV screen. This is a little bit different, isn't it? Describe that to me.
Much different. So we've essentially, the DaVinci Surgical Platform has given surgeons their eyesight back and unlocked their wrist. So you were talking about the straight sticks or the laparoscopy standard sticks that you guys currently are using.
Right.
Very stiff and rigid. The end-wristed instruments on the DaVinci Surgical System actually are fully articulating. It's got 7 degrees of freedom. So it's actually taken and allowed surgeons to replicate their open procedure and do it in a minimally invasive fashion.
Now this is important because you're bringing up a couple of things. We talk about articulation, we're talking about the movement of the hand, and what I think is so impressive about the DaVinci system is it gives the surgeon that movement, but it gives that surgeon that movement in controlled fashion. And you had mentioned this, it actually slows my hand, is that right?
Yes, there's motion scaling that is a part of the technology built into this, so the surgeon is in control of the instruments at all times. The robot is not self-thinking, it's not AI or artificial intelligence, it's not going to go off and do its own thing. Surgeon is operating just as he would standing over the patient. He's just sitting at the surgeon console a couple feet away, operating the same motion that he would. The actual design of the system gives the surgeon the control not only of the camera and the 2 operative arms, but he also has a 3rd arm to assist himself for a more precise and direct surgery.
And one of the things I'm going to bring two things kind of together here, because we talked about open versus what we call, it's a lot of people call Band-Aid surgery or the small surgery. That's one of the things that's so good about the DaVinci system is we're hoping to take a lot of these open cases that we're doing, which open means large incisions, and make them kind of the Band-Aid surgeries or the very small incisions. Is that correct?
That is correct. Unfortunately, still here in the Middle Tennessee area, we have a 70% open hysterectomy rate. And so this enabling technology is allowing surgeons to provide a minimally invasive approach to a broader base of patient, particularly to help drive down that 70% number.
And the other thing I want to bring out, as I said, two components here. The second component is cost. And I want to give you the opportunity to talk a little bit about the whole cost issue, because that's what we're facing in medicine today, almost with everything is a cost. How is this feasible?
Sure, and I think that's a better question suited to patients that have had a robotic procedure or a DaVinci surgery versus an open procedure. You look at shortened length of stay in the hospital, quicker return to life or normal life activities, and then post-operative pain, what that looks like compared between the two. And then if you look at a global economic standpoint as to that patient being able to get back to work at a much faster rate than they would from an open standpoint, I think that there's no doubt that it's financially feasible and worth doing. And, keep in mind, Dr. Williams, too, patients don't necessarily look at cost when they're looking for a procedure. They're looking for good clinical outcomes, and that's what surgeons that are robotically trained or on the DaVinci system provide to their patients.
And that's one of the most key points, and I think it's interesting that you said that, because that's true about doctors. What we want is good clinical outcomes, but we've got to make sure we've got good clinical outcomes with good financial feasibility. And I will tell you, the robot is changing surgery and will continue to change it in the future because the technology is just beginning. When we come back, we'll be joined by two surgeons who are actually doing the robotic system. We're going to talk a little bit more about the clinical aspects of this procedure. We'll be right back after these messages. Welcome back to Health in Today's Woman. Tonight we're having a great discussion about a system that really is changing surgery as we know it today. That's the whole idea of the robotic system or the DaVinci system. Now in our first segment we talked a little bit more about how we got here, from science fiction to the actual operating room. In this segment, I want to talk a little bit more about the clinical aspects that really are involved in robotic surgery. Now, to better help me do this, I've invited two very outstanding surgeons who are coming to talk about the robotics. One is Michael Numnum, who is a GYN oncologist at Tennessee Oncology in Nashville. The other one is my partner, Dr. Brad Chesney, who is a generalist OB/GYN at the Murfreesboro Medical Clinic. So I want to start off by telling y'all thank you for being willing to come out here and talk about this.
Thank you, Kelly.
Yeah, thanks for having us.
The first thing I'm going to start off with you, Michael. I really want to address this whole idea of how the technology has changed your practice. Because, I mean, this really is, to a lot of people, science fiction.
Sure.
How has it changed your practice?
Well, our specialty as a whole has radically changed our specialty as a whole. You know, we deal primarily with just a few cancers, usually cancers of the cervix, cancers of the uterus, and cancers of the ovary. And specifically for cervical and uterine cancers, those are fairly curable cancers, but they required a fairly morbid operation previously. Okay. Morbid meaning loss of complications after surgery. Right. And what we're doing now is we're taking a surgery that required a fairly big incision and using small incisions as Scott described and turn it into a much less morbid operation, and we're actually getting, the patients are having less pain after surgery, less bleeding. As far as a cancer operation goes, we're getting better lymph node dissections, more lymph nodes, which is important, and we are getting better margins with the robotic platform. And so it's made a radical difference in the way we practice our medicine these days.
And let me explain to you margins, because a lot of people don't understand what that is. When you remove something, you leave something behind. And a margin is you want that part left behind to be normal and all the bad stuff to be taken out. And so I want to make sure people understand what margins, and that is really important because margins are the key, because whenever you're doing cancer surgery, you want the whole cancer encased and take it out in a whole, right?
Exactly right, Kelly. You know, it's kind of interesting. A patient, when I was describing this type of operation to one of my patients a couple months ago, she said, this doesn't sound like the right thing for me. I want you to open me up with as big of an incision as possible and do it that way because you can see everything. Well, the reality is, and Brad can speak to this as well, but because of the 3D platform, you can actually see better with robotic surgery than you can with your own eyes. And so it makes a big difference for cancer surgery.
And one of the things I want to mention real quick, and then I want to get to Brad, and that's the whole idea that you're able to do some really difficult cases a lot better now than you were before, aren't you?
I think so. I think so. You know, the actual amount of time you spend in the operating room with the robotic platform is actually a little bit more. You work a little bit harder in the OR to do these difficult cases because it pays off in the long run, because the patients do better, they have less pain, and they get out of the hospital and back to life and society a little bit quicker.
Now, I want to turn this question to Dr. Chesney, because, Brad, this is an interesting thing for us because, cancer we talked about, and even we had this discussion months ago about how does this fit into the generalist OBGYN world? How has this changed your practice?
Well, I think one of the things that's happened in the past couple of decades is that the C-section rate has gone up.
No question.
So we're at 30% C-section now, which is a pretty big number.
Yeah.
And as people continue to come through and still have reasons for a hysterectomy or another surgery like that, those patients in the past haven't really been a very good candidate for a minimally invasive surgery. Each time you have a C-section, increases your scar tissue buildup and that sort of thing, so it makes the actual operation very challenging. Well, with robotics, we're able to take something that would have been an open case and all of a sudden make it a minimally invasive case, which is so much easier on the patient.
And one of the things I think is important too is that we're able to take some cases that were large uteruses that we used to have to do open, we're now able to do as these, what I call Band-Aid surgery. A lot of people call Band-Aid surgery or minimally invasive surgery. Is that correct?
Yeah, that's true too. It just, like Michael was saying, it gives you so many options that you didn't have before. There's a camera for each eye, which is how you get that three-dimensional view. And like you mentioned in the first segment, you can articulate and get into spaces in 360 degrees that you really couldn't even do with a human hand. And all of a sudden you've got the capability to do that, so you can see things and approach things in a much different way and take a case that would have been challenging before and you would have said, no, I can't do it the easy way or the easy way for the patient. We're just going to have to open her up, and now we're able to do it in this way. It's just such a big difference, big advantage.
Now, one of the things I want to make sure we're dealing with and I know Brad personally very well, we're dealing with two outstanding surgeons, and that's one of the things about dealing with the robot is, the robot is a robot, the surgeon is a surgeon. You got to have an outstanding surgeon to have an outstanding outcome, whether they're using the robot or not. And that's something that I think we need to make sure, because a lot of people talk about this is the cool way to do it. But the honest truth is, surgery's still surgery, and you still got to get the outcome, and you got to have a quality surgeon in the end. To Brad, I would ask, what do you say to that patient? This is the cool thing to do now, or it's kind of the new technology. Some people say, I don't want the new technology, like Michael was mentioning earlier. Some say, I do. But, it isn't a candidate for, not everybody's a candidate for this. There are some people that are good and some people aren't.
Sure.
Is that right?
Sure. Yeah, I think that's right. And I guess my first response would be, it is cool. I mean, we're having a great time with it. It's exciting, and it's cool from the standpoint that we're helping people in a way that we've never been able to do before. Like you said, every technology has limitations, and not every patient is going to be a good patient for this. But it's amazing how many people are good patients for this as well. So it's pretty exciting stuff.
And kind of from your standpoint, we're not just using this for laparoscopic or for hysterectomies. We're using it for a number of different things. Is that correct, Mark?
We are. As I said, a lot of nodal dissections. For example, a patient that has already had a hysterectomy and has a certain type of cancer that needs a nodal dissection, lymph nodes removed. Fertility sparing surgery. Say there's a woman that has an early cervical cancer and she has not finished having children.
Right.
We can do these types of more radical procedures with this, where we can remove the cervix, keep the uterus, and there is a potential to have children on down the line. It's very interesting. It's not, it is not 100% of my practice by any means, and so I think that is an important point. One of the drawbacks of robotics is the lack of tactile feedback.
Right.
And that's very important. In other words, that means I cannot feel what I'm operating on.
Right.
And so there's certain operations, at least what I do, that I have to have my hands on it, and we haven't overcome that yet. And so it's not for every patient, and especially for patients with large ovarian tumors and things like that.
And I think that's important because it's great to get the new cool thing, but it's also important to make sure that we're doing the right operation. Exactly. And that's one of the things that, as I know both these people, it's very important that we're not just doing this because we can. We're doing this because it's better for patients. And I know Brad, and I know Michael, I know myself, and doctors want to take good care of people, and that's the important thing. We will be right back to these messages, and I want to bring up to Brad on the next segment a little bit more about how he's using it in his practice. We'll be right back after these messages. Welcome back to Helping Today's Woman. Tonight we're talking about the new technology of robotics and how it's affecting our surgical care in the modern world. Now, at the end of the last segment, I said I want to talk to Dr. Chesney because I want to hear a little bit talk to Dr. Numnum about what you're doing other than just hysterectomies with the robot. And then I want to talk a little bit about the cost involved in robotics, because I think that's something that as we sign the future, we're going to have to discuss. But tell me a little bit about what you're doing other than just hysterectomy, because everybody thinks, well, I just need my hysterectomy this way. But you can do a lot of other stuff, can't you, Brad?
Yeah, you sure can. I think in my practice right now, we're taking people who have an ovarian mass that we think is benign, that we're fairly confident we don't need Michael for. We love having Michael, but sometimes we don't need him. But you can take a challenging case like someone who's had endometriosis and 3 previous surgeries, and they've got a lot of scar tissue, and you've got to get a benign ovarian mass out. You can do that with this robotic surgery that you would have been intimidated and probably would have had to open with previously before we had this technology. So that's one thing we're doing with it. And probably the main thing, and some procedures are done for infertility as well, like removing fibroids is another big one.
And I know that the one thing that I thought was so interesting about the robot was the ability to do endometriosis, because endometriosis, especially with infertility, and being able to do some, you get so much scarring with endometriosis. It's a great opportunity to take on that and not have to do that laparoscopically.
Definitely.
Now I want to take a little bit of a turn because I want to mention that could give you a chance to talk about, this is not all about just hysterectomy, and I want to talk a little bit about the cost. The reality is we're facing a new time in medicine, and whether we want everything to be about care, we do. There's no question we're physicians, we want it to be about care. But with the buzzword is changing now, it's care with financial responsibility and financial feasibility also. So I want to talk a little bit about, the big question everybody asks in medicine and outside of medicine is, this is a great technology, can we afford it? And I think that that's something I want to hear y'all say from the clinical aspect. We hear about it from the insurance aspect. What about the clinical aspect? Describe to me, is it financially feasible, Michael?
Well, there's 3 answers to that.
Okay.
So I think there's 3 ways to answer that. If you look at it from a standpoint of walking into the operating room, the actual cost to do this surgery versus older methods, open surgery, it's more expensive than a traditional open operation. Okay. If you look at it, and so the answer number 2, if you look at it from a hospital standpoint of how much does it cost to take care of this patient from the time they walk in to the hospital to the time they walk out of the hospital, I think it's probably about the same because the patients are going home about half the time, so you're not tying up a hospital bed for another 3 or 4 days as with traditional open type surgery. And I think the most important answer, and I think Scott alluded to this, is what's the cost to society.
Right.
I think that if you look at it as a cost to society standpoint, I think it's actually more beneficial because women are getting back to work quicker. They are getting back to taking care of loved ones quicker, children, mothers. They're getting, from my standpoint, they're getting to radiation quicker. They're getting to chemotherapy quicker. They're getting through this journey a little bit faster. And so I think from that standpoint, I think it is more cost effective from a societal standpoint.
And that's important because cost is not just about money. There's a lot more to cost than just saying, this is what it costs. I mean, it costs this much to do the procedure, but you know what, it costs me this much to do an open case, but if I can save you 3 days down the line or get you back to work in 2 weeks versus 4 to 6 weeks, which is what we usually tell with a hysterectomy patient, I think that's an important thing. Now, Brad, what about you? I mean, I want to hear your take on this because it's a little bit easier, I think, sometimes to argue from a GYN standpoint or GYN oncologist standpoint because you're talking about cancer. People don't argue with money about cancer. They say, just fix it. In our world, it's a little bit different.
Sure.
We have a little bit more of an explanation because they're like, it's not cancer. Why can't you do this as an open case? How do you answer that?
Well, I think the main people that we have to explain that to are the hospitals because they're the ones that in general are purchasing the robot. And that's the big upfront cost is the purchase of the actual technology. But from the standpoint of the patient, the charge is no more. So it doesn't cost the patient or her insurance company any more than it would have if we'd done a laparoscopic assisted vaginal hysterectomy, for example. So the cost of the patient of having the procedure is neutral, essentially neutral. And then, like Michael was alluding to a little bit, traditionally, if you had to do an open hysterectomy, the patient would have been in the hospital for 2 or 3 days. Now we're sending them home on the same day. We did it that morning. We send them home that afternoon. So it's less time in the hospital, much quicker recovery. They're back to work for the most part, depending on your job, of course. If you work in a factory, it's different. But many people are back to work in 10 days. So, that's a big part of it. And then I think the other part that we haven't said, and I feel compelled to bring up, is less pain, dramatically less pain.
Right.
I've had several patients, shockingly, who required no pain medication after surgery, which just blows me away. Less blood loss. Right. And so you put all that together, and all of a sudden these people are reaping a lot of benefits that maybe you can't put a cost number on or cost savings number on, but I think it's a big deal.
And one of the other things I want to mention, because I think it's also important, is we're dealing with 2 outstanding surgeons, and I'm not just saying that. It's true. I mean, I've seen Brad operate. I know he's a very good surgeon. I know Michael is. Is this something that everybody should be offering? And I think a lot of people say, should every surgeon, if my doctor's not offering this, should I be concerned that my doctor's not offering this? And I think it's a great question because you know what? I honestly, it's not necessarily they don't think that I'm a good surgeon. It's is this something I want to take on? Or do I want to let somebody else take it on and learn, and let me do what I'm good at? And I think that's important, because I think a lot of, as the future arises, we're going to be talking about, well, they don't do robotics. Real quick, what do you think about that? I'll go to Brad real quick.
I think that's a tough question. I mean, for me, I struggled for about 2.5 years. Scott and the people that worked with him convincing me that this would be a good thing for my practice, and because it's a big commitment from the surgeon as well as far as training goes. There's a lot that goes into the training, and there's a lot of time that's set back, like Michael alluded to earlier. It takes a lot longer, although I think as I continue to get better at this and do more, that I'll cut that time down a little bit, but it is a big commitment on our part. Is it for every gynecologic surgeon out there? Hard to say. I don't know. As you alluded to earlier, maybe the technology is going to improve and make it be even easier. I'm not sure. But for me personally, it's been fantastic.
We'll be right back after these messages. Welcome back to Helping Today's Woman. Tonight we've had a great discussion about a new technology that really is changing surgery. That's the whole idea of robotics. And I want to say a special thank you to Dr. Brad Chesney and Dr. Michael Numnum for both being willing to be here tonight. This is something that we're going to have to deal with, the financial issues and the cost issues, but it really is going to change medicine in the future. We are doctors, and the most important thing is we want to provide good care for our patients. We thank you for being here tonight, and we hope you've enjoyed the discussion. We'll see you next week.